In 1925, Sir Henry Soter reported the first mitral commissurectomy in the British Medical Journal. He wrote the heart should be as amenable to surgery as any organ. He saw the main problems as being maintenance of blood flow, particularly to the brain, while surgery was being performed. The first real advances occurred in the late 1940s and early 1950s, driven by surgeons who had gained confidence and experience under the pressure and opportunities provided by war, followed by the development of cardiopulmonary bypass in the mid 1950s. Recently, the well-being and lifespan of patients with congenital, valvular and degenerative heart disease has improved drastically due to the advances in the range, complexity and technical expertise in cardiac surgery. Cardiopulmonary bypass. Cardiopulmonary bypass. It was first used successfully in 1953 by Gibbon and, and has since revolutionized cardiac surgery. It can be employed in any procedure in which the heart and lungs need to be stopped temporarily and their function replaced artificially. Before Gibbon's work, valve surgery under direct vision would not have been possible, nor would the precise reconstructions need to treat extensive coronary artery disease. Much of the success of modern cardiopulmonary bypass surgery is attributable to the development of new biomaterials and sophisticated oxygenating device, as well as a greater understanding of the pathophysiological consequence of coronary cardiopulmonary bypass. Surgical approach to heart. Surgical approach to heart. The heart is approached mainly by a median sternotomy. The heart is approached mainly by a median sternotomy. An incision is made from the suprasternal notch to the lower end of the xiphisternum. An incision is made from the suprasternal notch to the lower end of the xiphisternum. The sternum is divided and retracted to expose the thymus superiorly. Thymus will be exposed, and the pericardium inferiorly. The thymus, although atrophic in adults, often remains relatively vascular. The thymus and the pleura are dissected from the pericardium and pericardium is opened. Dissected from the pericardium. Heart. This is pericardium. The thymus and pleura are dissected from the pericardium. Thymus and pleura, covering of the lungs. covering of the lungs, they are dissected from the pericardium. This is pericardium. And pericardium is opened. Before cannulation for CPB, cardiopulmonary bypass, the patient is fully heparinized. The patient is fully heparinized. Other incisions that can be used include left or right anterolateral thoracotomy for minimally invasive operations or for specific operations on the descending aorta. Other incisions that can be used include left or right anterolateral thoracotomy. Right anterolateral thoracotomy or left anterolateral thoracotomy. Initiating cardiopulmonary bypass. Initiating cardiopulmonary bypass. Before that, we will study about alternative uses of cardiopulmonary bypass. They are rewarming from profound hypothermia, resuscitation in severe respiratory failure, as an adjunct in pulmonary embolectomy, in single and double lung transplantation, in cardiopulmonary trauma, in certain non-cardiac surgical procedures, example, resection of highly vascular tumors and tumors invading large blood vessels Initiating cardiopulmonary bypass, they include arterial cannulation, venous cannulation and cardiopulmonary bypass circuit. Arterial cannulation. Number 1, arterial cannulation. Conventionally, the great vessels are exposed and an aortic perfusion cannula is inserted into the ascending aorta. Conventionally, the great vessels are exposed and an aortic perfusion cannula is inserted into the ascending aorta. This is ascending aorta, which is inserted an aortic perfusion cannula. An aortic perfusion cannula is inserted into the ascending aorta, held in place by purse string suture. Air is excluded and the cannula connected to the bypass circuit. Alternatively, when it is inadvisable in aortic dissection, impractical aortic root surgery, or impossible severe addition to the cannulate the aorta, alternative atrial cannulation sites can be used. Such as femoral artery or the axillary artery. Alternative to aortic ascending aorta, alternatives are femoral artery and axillary artery. The latter has recently been gaining more popularity. That means femoral artery and axillary artery are gaining mass popularity as it provides antegrade flow and can be utilized to provide selective cerebral perfusion in complex aortic operations. Axillary cannulation. Axillary cannulation has the theoretical advantage of reducing thromboembolic events. When compared to femoral cannulation. Then venous cannulation. Aortic cannulation. Number 2, venous cannulation. Venous cannulation. A persisting suture is placed around the right atrial appendage and a single two-stage venous cannulation is placed to establish venous drainage. The venous pipe has end holes that side in the inferior vena cava. The venous pipe has holes that end holes that sit in the inferior vena cava. This is inferior vena cava. And side holes that sit in the right atrium. This is right atrium. To take drainage from the superior vena cava. This is superior vena cava. Alternatively, the superior and inferior vena cava may be cannulated separately. Superior vena cava and inferior vena cava may be cannulated separately to gain better control over the venous return and to facilitate surgery within the right atrium. Venous drainage from the femoral vein can offer an alternative. Particularly during thoracic aortic or minimally invasive procedure. During thoracic aortic or minimally invasive procedures. Cardiopulmonary. Number 3, cardiopulmonary bypass circuit. Cardiopulmonary bypass circuit. Cardiopulmonary bypass circuit. Once the circuit is connected, the cardiopulmonary bypass machine, the pump, gradually takes over the process of circulation and ventilation. This is the components of cardiopulmonary bypass circuit. Cardiotomy suction blood. Filtered heart shell venous reservoir. Then blood pump, flow probe, blood inlet line, oxygenator or heat exchanger. Then recirculation line. This is recirculation line. This is blood outlet line directed towards arterial filter. This is arterial filter. And then arterial blood to the patient. This is arterial blood which goes towards patient. This is venous blood from the patient directed towards filtered heart shell venous reservoir, Once full flow is established, the required cardiac output depends on the body surface area of the patient. Body surface area of the patient. The ventilator is stopped and the heart can be isolated from the rest of the circulation. Blood is drained from the heart to the venous reservoir. Blood is drained from the heart to the venous reservoir using the siphon effect by gravity, as it is usually placed 50 to 70 centimeter below the level of heart and oxygenated using an oxygenator This is oxygenator that flow and that allows gas exchange across its membrane. Blood is then pumped to the body by bypass machine via aortic cannula. The core systemic temperature can be lowered by passing the returning blood through a heat exchanger that can reduce the metabolic demands of the tissues. The degree of cooling is managed according to the severity and complexity of the surgical procedure, as well as the surgeon's preference. The blood is also filtered to remove particulate emboli and return to the systemic arterial circulation via a pump. Suction pumps can be employed to keep the area around the heart clear of blood and to decompress the heart when used as vents. Myocardial protection. Once CPB has been established, the ascending aorta is usually myocardial protection. Once cardiopulmonary bypass has been established, the ascending aorta, this is ascending aorta. The ascending aorta is usually cross-clamped to obtain a bloodless operative field. The heart ceases to eject and becomes anoxic due to inhibition of coronary blood flow. Coronary blood flow is inhibited. So coronary artery. This is coronary artery. Permanent myocardial damage can develop within 15 to 20 minutes. Therefore, most cardiac operations require some form of myocardial protection. Techniques of myocardial protection and the operative management of the myocardium have had a significant impact on the complexity of the cardiac surgery. The methods of myocardial protection include intracoronary infusion of a cardioplegic solution. Integrate. The methods of myocardial protection include intracoronary infusion of a cardioplegic solution. Intracoronary infusion of a cardioplegic solution. Infusion via coronary sinus retrograde. Intermittent cross-clamp fibrillation. Intermittent cross-clamp fibrillation cross clamp fibrillation and total coronary arrest Cardioplegic solution vary in terms of temperature. Cardioplegic solution vary in terms of temperature, pH, arresting agent, osmolarity, and the presence of red cells and the other factors. Most solutions contain potassium as the arresting agent. This is the arresting agent. Potassium arrests the heart in diastole. Potassium arrests the heart in diastole by depolarization of the myocyte cellular membrane. By depolarization of the myocyte cellular membrane. Cold isotonic crystalloid or blood solutions aid myocardial protection by reducing metabolic requirements through local hypothermia. Cold, that means 4 to 10 degrees Celsius, isotonic crystalloid or blood solution aid myocardial protection by reducing the metabolic requirements through the local hypothermia. Warm cardioplegic solution. Cold, then warm cardioplegic solution. On the other hand, may facilitate better myocardial repair recovery post-operatively by aiding activation of intramyocardial enzymes. Intermittent cross-clamp fibrillation. Intermittent cross-clamp fibrillation is a technique in which intermittent ventricular fibrillation is induced by a small electrical charge. The heart does not eject and is relatively still but not bloodless. The aorta is cross-clamped to render the heart ischemic. The heart can tolerate short periods, 10 to 15 minutes of 10 to 20 minutes of ischemia, provided the heart is reperfused when the cross clamp is released. And allowed to beat following cardioversion for short periods during operation. Total circulatory arrest becomes necessary when visibility and clarity of the operative area is crucial. As in pediatric surgery or in surgery of the ascending aorta and arch of aorta, cardiopulmonary bypass is instituted and the core body temperature reduced to 15 to 18 degrees Celsius. This is 18 degrees Celsius. Profound hypothermia. The metabolic rate of all organs of the body is reduced by 50%. The metabolic rate of all organs of the body is reduced by 50%. With every 7 degrees Celsius drop in the temperature. The metabolic rate of all The metabolic rate of all organs of the body is reduced by 50% with every 7 degrees Celsius drop in temperature. Using this technique, circulatory arrest can be tolerated up to 20 to 30 minutes. Up to 20 to 30 minutes. Additional cerebral protection can be provided with ice packs placed around the head, pharmacological agents, and cerebral perfusion techniques. Discontinuing discontinue cardiopulmonary bypass. Discontinuing cardiopulmonary bypass. At the end of the procedure, air must be meticulously excluded from the cardiac chambers. Once perfusion is restored to the coronary arteries, by removing the cross clamp, the heart may hit spontaneously. If ventilator fibrillation is present, cardioversion may be required. Epicardial pacing wires may be placed to treat postoperative bradycardia or heart block. The patient is rewarned acidosis and hypokalemia. Acidosis and hypokalemia. Acidosis and hypokalemia are corrected and ventilation is restored. The heart gradually takes over the circulation where the arterial flow from the CPB cardiopulmonary bypass machine is reduced. When the blood pressure is acceptable and the surgeon is confident that the heart function is adequate, CPB is discontinued. The cardiopulmonary bypass is discontinued. The cannula are removed and the anticoagulation is reversed by administering protamine. Complications of CPB, cardiopulmonary bypass. Complications of CPB. CPB is a complex technique and require careful interactions and communication between surgeons, anesthesiologists, and perfusionists to ensure that the patient remains safe. Difficulties can occur during cannulation, aortic dissection or atrial injury. During cannulation, aortic dissection or atrial injury. At the start of CPB, or that means oxygenator failure, and at the end of the CPB, that means coagulopathy. At the end of the coagulopathy. Many complications can occur following blood exposure to the non-physiological surface of the CPB circuit. This leads to the activation of inflammatory cascades, giving rise to a post-CPB systematic inflammatory response syndrome. Systematic inflammatory response syndrome that can ultimately lead to multi-organ failure. SARS can lead to multi-organ failure. Recent understanding of the impact of cardiopulmonary bypass, that means CPB, on the coagulation cascade and the patient's inflammatory response has resulted in the development of smaller mini CPB. Which has demonstrated some advantage in terms of post-CPB inflammatory response and blood transfusion requirement. Alternative methods include surgery on beating heart of pump. Although despite some disadvantages, use remains restricted to coronary artery bypass grafting, and long-term outcomes are still a matter of debate.